regarding this echocardiographic analysis. The discussion will be at the end of the session, and I will have, some questions to you. Now we will continue with the role of preoperative cardiac MRI in congenital mitral valve anomalies, and I believe it's a Zoom presentation of Dr. Kamperou. Can we continue with this?
Yes, of course. Can you hear me now?
Yes, very good.
Okay, very nice. Thank you. Okay. Just give me 1 second because I have a little bit of PowerPoint hiccup. Okay, it looks good now. Good morning and thank you for the invitation to present here today. My name is Dr. Kamperou. I'm an imaging cardiologist. We're here today to comment on the role of preoperative cardiac MRI in congenital mitral valve anomalies. CMR has emerged as a fundamental tool for preoperative assessment in congenital mitral valve disease, particularly when echocardiographic data is insufficient or discordant with clinical findings. Congenital mitral valve anomalies are rare, heterogeneous abnormalities involving the leaflets, annulus, and subvalvular apparatus. Because these lesions are uncommon, particularly in adults, they are often under-recognized and may remain undiagnosed for many years. In many patients, milder anatomical variants and compensatory cardiac mechanisms may delay the onset of symptoms, so the diagnosis can only become apparent later in life. Several structural abnormalities have been described. Cleft mitral valve is commonly associated with AV septal defects. Other lesions involve the subvalvular apparatus, such as parachute mitral valve or supramitral ring seen in Son complex, both of which can produce left ventricular inflow obstruction. Rare anomalies, such as mitral arcade or hammock mitral valve, are characterized by shortened or absent chordae with direct papillary leaflet attachment, resulting in restricted leaflet motion and mixed mitral valve dysfunction. These congenital abnormalies, hiccups, leaflet, okay, very good, okay. These congenital anomalies often mimic more common acquired diseases, particularly rheumatic mitral valve disease, which makes diagnosis challenging. In addition, the complex and highly variable subvalvular anatomy may be difficult to visualize with standard 2-dimensional echocardiography. For this reason, multimodality imaging plays a critical role in surgical planning. Advanced techniques such as 3D echocardiography, cardiac CT, and CMR allows more detailed visualization of the mitral valve apparatus and associated congenital lesions, improving diagnostic accuracy and helping guide management. The decision to refer for surgery in congenital mitral disease has evolved from purely watching for symptoms to proactive hemodynamic approach. While symptomatic presentation, just give me a second because I have a little bit of a problem with my presentation. Can you give me the mouse? Thank you. Okay. Okay, sorry for that. Current slide, the next one. All right. Okay, sorry for that, apologies. The 2025 guidelines emphasize that we must now look heavily at hemodynamic severity and trigger indices. A mean gradient exceeding 10 millimeters of mercury in mitral stenosis or ejection fraction greater than 40% now are definite triggers for intervention. These indices are superior to echocardiography, which frequently underestimates severity, particularly in the presence of eccentric sets. Furthermore, we are monitoring ventricular atrial remodeling, with much higher precision. Progressive left ventricular dilatation, defined as an end-diastolic volume index over 100, or the onset of new onset atrial fibrillation are critical signals that the heart's compensatory mechanisms are failing. The most significant shift in 2025 clinical era is the move towards intracardiac energetics. Waiting for a drop ejection fraction is no longer the standard, as IF can often be preserved even in advanced disease, and 40-flow CMR is uniquely positioned to identify energetic insufficiency, specifically high viscous energy loss and turbulent kinetic energy. These parameters can serve as much earlier biomarkers for surgical referral than traditional volumetric measurements. Echocardiography remains the first-line imaging modality for evaluating mitral valve disease because of its excellent spatial and temporal resolution and its ability to assess valve morphology in real time. However, CMR provides important complementary information, offers unrestricted imaging planes, radiation-free three-dimensional datasets, allowing for comprehensive visualization of the entire mitral valve apparatus, including the leaflets, chordae tendineae, papillary muscles. This is particularly valuable in congenital mitral valve anomalies, where detailed assessment of the subvalvular anatomy is essential. It can provide high accurate and reproducible measurements of left LV volumes and function, enables robust quantification of MR or stenosis using volumetric and flow-based techniques. A typical CMR protocol includes cine SSFP sequences for valve motion and ventricular function, phase contrast imaging for flow quantification, 3D whole heart sequences for anatomical relationships and tissue characterization with late gadolinium enhancement and T1 mapping. Emerging techniques as 4D flow further expand our ability to evaluate complex intracardiac hemodynamics. Together, these sequences allow CMR to provide a comprehensive assessment of mitral valve anatomy, hemodynamics, and myocardial remodeling in one single examination. A particular strength of CMR is the comprehensive evaluation of the entire mitral valve apparatus. Beyond leaflet morphology, CMR provides detailed visualization of the subvalvular structures, particularly the papillary muscles and their spatial relationship with the ventricular wall, to a lesser extent the chordae tendineae. This becomes especially important in congenital mitral valve disease, where abnormalities are often complex and cannot always be fully characterized by imaging modalities limited by acoustic windows. By providing unrestricted imaging planes and three-dimensional visualization of the entire subvalvular apparatus, allows precise morphological characterization, contributes to modern surgical planning, which increasingly relies on detailed preoperative anatomical definition, with the goal of preserving the native mitral valve whenever possible. CMR enables precise volumetric quantification of left atrial and ventricular volume, allowing accurate assessment of remodeling secondary to mitral valve disease. CMR is the established gold standard for volumetric assessment because it provides direct, high-precision 3D quantification of cardiac volumes without geometric assumptions or acoustic windows dependencies that often limit echocardiography. Compared to echo, CMR volumetric analysis has been shown to have superior correlation with surgical outcomes. In mitral regurgitation, CMR provides a highly reproducible quantitative assessment. Using the principle of conservation of mass, the regurgitant volume can be calculated by combining ventricular volume analysis with flow measurements. The ventricular stroke volume is obtained from cine imaging, and forward flow in the ascending aorta is then measured using phase contrast imaging. The difference between the two values corresponds to the mitral regurgitant volume. However, in patients with intracardiac shunts or complex congenital disease, this approach may not be reliable. Part of the left ventricular stroke volume may pass through the shunt rather than the aorta, meaning the standard cannulation can no longer represent only mitral regurgitation, and alternative strategies are deployed, such as comparing left-hand right ventricular stroke volumes, measuring pulmonary artery flow, integrating multiple flow measurements into anatomical findings. Therefore, in complex congenital anatomy, accurate MR quantification usually requires a multiparametric CMR approach. Beyond evaluating the mitral valve itself, CMR is also extremely valuable for the comprehensive assessment of associated congenital abnormalities, which are frequently present in these patients. For example, it allows identification of different components of the Schwann complex, AV canal defects. The most valuable sequence in this perspective is the 3D PSSFP sequence, which is particularly useful in visualizing supravalvular mitral rings, subvalvular membranes, often more clearly than conventional echocardiography. Can provide accurate assessment of associated orthopathy, and it can help identify other congenital abnormalities that may influence management, such as AV septal defects with cleft mitral valve, anomalous coronary origins that may complicate surgical access, and venous or atrial anomalies such as chord triatriatum or anomalous pulmonary vein return. For this reason, whole heart evaluation with CMR is essential for comprehensive assessment and optimal surgical planning. One of the particular strengths of CMR is its ability for tissue characterization, allowing us to assess myocardial scar and the extent of endocardial fibrosis, which in congenital mitral valve disease may occur with or without direct involvement of the valve apparatus, but still has important functional consequences. Beyond simply defining anatomy, CMR provides insight into the biological state of the myocardium using techniques such as late gadolinium enhancement. We can detect fibrosis not only within the ventricular myocardium, but also involving the papillary muscles, the subvalvular apparatus. This information is clinically relevant as it may identify patients at higher arrhythmic risk, give insight into ventricle's recovery capacity after a successful repair, and also can identify fibrous bridges and strands that may alter the surgical approach. When this information is combined with feature tracking and myocardial work analysis, we begin to understand not only what the structural lesion is, but how the ventricle is responding to it, and insight into the functional reserve of the ventricle. This allows intervention at the stage when myocardial recovery is still possible. In this way, multimodality CMR assessment helps ensure that surgery really results not only in an anatomical correction of the valve, but in true physiological recovery of ventricular function. Four-dimensional flow CMR is an emerging technique that provides a time-resolved three-dimensional map of blood flow throughout the cardiac circle from a single volumetric acquisition. Unlike conventional phase contrast imaging, it measures blood velocity at all three spatial directions over time, allowing comprehensive visualization of intracardiac flow patterns. This makes it particularly useful in congenital mitral valve disease, where regurgitant jets are often eccentric or multiple. A key advantage is a retrospective plane reorientation after acquisition. Measurement planes can be positioned exactly perpendicular to the true flow vector, ensuring accurate quantification of complex jets. In addition, 4D flow enables retrospective valve tracking, which follows the motion of the mitral annulus during the cardiac circle. This is particularly important for the mitral valve, given its significant through-plane motion and saddle-shaped geometry. This case demonstrates primary mitral regurgitation caused by a congenital cleft mitral valve with preserved leaflet motion corresponding to Kamperou type 1 dysfunction. Cine MRI shows a split of the anterior leaflet at the A2 segment connected by a raphe. 4D flow imaging reveals systolic flow acceleration in the LVOT and an eccentric regurgitant jet towards the left atrium. Using volumetric and 4D flow quantification methods, the regurgitation is consistently classified as moderate. The next example demonstrates comprehensive CMR assessment of mitral valve stenosis. Cine imaging shows restricted leaflet opening, significant left atrial enlargement, direct planimetry on the short axis measures a mitral valve area of 0.8 centimeters square consistent with severe stenosis. 4D flow visualization identifies the location of the peak flow and acceleration across the valve and allows quantification of transmitral velocities, yielding a peak gradient of 44 millimeters of mercury and a mean gradient of 20, confirming hemodynamically severe mitral valve stenosis. Beyond visualization, 4D flow provides novel hemodynamic biomarkers. These include turbulent kinetic energy and viscous energy loss, which quantify the energetic cost of abnormal flow patterns within the heart. Turbulent kinetic energy is highly sensitive to flow disturbances caused by even mild regurgitant or stenotic lesions, while viscous energy loss reflects the additional workload imposed on the ventricle. These parameters may help us guide the timing of surgical intervention. And importantly, preoperative measurements obtained with 4D flow CMR have been shown to correlate closely with postoperative reverse remodeling of the left ventricle after mitral valve repair. Finally, visualization of path lines and streamlines allowed qualitative assessment of vortex formation and flow stasis, providing further insight into the hemodynamic consequences of complex congenital mitral valve lesions. To conclude, the role of CMR in congenital mitral valve disease has evolved from a purely descriptive tool into a comprehensive hemodynamic auditor. In the 2026 clinical landscape, we have moved beyond the watchful waiting of the echocardiographic era. And first, we must acknowledge the CMR as the gold standard for volumes. And second, CMR provides the surgeon with a visual roadmap. The most transformative change, however, is our shift towards intracardiac energetics. By qualifying wasted work through 4D flow energy loss, we can intervene at the precise moment the heart begins to struggle. When we pair this with tissue characterization, we can finally distinguish between a heart that can recover and one that is already irreversibly stiffened by fibrosis. This is a list of resources, further reading recommendations. Thank you for your time.
Dr. Kamperou, for this presentation. I will not wait for the end of the session to ask you this question, because sometimes, you know, especially in some complex, morphologically complex mitral valve abnormalities, I have the impression that the cardiac MRI is not enough. Do you believe that, especially in those cases, we have to combine the cardiac MRI with a 3D or 4D CT, cardiac CT scan, in order, you know, to reinforce the accuracy of the imaging? Even, you know, there is a lot of publications coming up now with 3D printing of the mitral valve. in order to define better, this morphologically complex cases?
This is actually a spot-on question. We are still in the era of multimodality imaging. There is no way that a single modality can claim the entirety of anatomical and physiological consequences of any valve or congenital, otherwise congenital lesion. So yes, definitely, and each modality complements the other. The thing with the MRI, though, is that it has given us some tools to really understand the hemodynamics and the insight in the physiology. I think it cannot be surpassed by any other modality. And it gives us new questions more quickly than the answers that it gives, yes, which actually is the cost of any real advancement in any kind of area.
Thank you. There is another question from the audience. Yes, Professor Marek.
It's more about the, what is the gold standard? So the gold standard imaging valves, it's echocardiography, full stop. So now we have the opportunity to, and we should actually use the more 3D echo. And the 3D echo allows to fuse the all imaging together with the CT. MRI, I would prefer still to use as the additional information for the hemodynamic data. But definitely, if we talk particularly in the children, the gold standard is echocardiography. It's the far the best imaging because of the temporal resolution, because of the spatial resolution. The CT, it's getting better, and now a lot of places, they fuse the CT and 3D echo. I don't know, have you heard about the new Pioneer GE machine? So you can put the USB or drive with the CT, and you can merge the CT and 3D echo. So this is the fusion of imaging is definitely the future. And you can do it also in the cath lab, the fusion for catheter intervention. So you need to pick up each part and the best modality from each technology we have. So we have the echo, we have the CT, we have the MRI. And everything, all the future, it's getting towards the merging imaging, taking the best of each. So this, the even more difficult issue is, do we rely on all these numbers, cutoff limits? No, in children, it's definitely not, because each child is very complex. We need to put everything and put the puzzle together to understand the case. So it's good to have the cutoff limit for regurgitant fraction, 45%. Why? If you have the simple anterior cleft, and Professor Kalangos will fix it in the 5 minutes in theater, why to wait for the 45%? We should do it 20%. We should do it in the smaller child rather than the bigger child. So clinical picture, it's extremely important. And what can we treat? How can we treat? Sometimes the morphology is so complex that there is the very high risk of the valve replacement. So then you can wait. You can probably even exceed the 45% regurgitation as long as you know that the LV function is well preserved. So the beauty of the imaging, that it's rapidly developing. We have the AI. I don't have time to talk about the AI, but certainly the future. And we have the option of the imaging fusion. This is the future of the cardiovascular imaging.
Professor, thank you very much for your comment. I apologize, I cannot for the life of me open my video. I'm trying, so I hope this is not perceived as rude, being a voice in the room. You're absolutely right. This is the forefront of the vitral, the valve assessment. The CMR remains the golden standard in volumetry. And in quantifying the volumes, the stroke volume, the forward volume, and unfortunately echo cannot achieve this level of reproducibility. So it is a reproducibility and correlation with anatomical models, and CMR is the golden standard of that, not the whole of the valve assessment. And the temporal resolution and the spatial resolution required for valval assessment, yes, CMR does not have that. But, and this is a very interesting point about how we deal with small volumes, with small patients. And this is where the CMR will prove in the future, not currently, but in the future, valuable. Exactly because of the new 4D flow kind of assessment, it can give, hopefully in the future, tailored assessment of the hemodynamic sequela of a defect in an individual heart. And this, I think, is the holy grail, the individual assessment for an individual treatment and surgical approach.
I don't think there is any disagreement. This is just what I have said, that we want to pick up the best of each modality. So no doubt that MRI is fantastic, gold standard for functional measurements. I would rely on MRI regurgitant fraction rather than echo, because regurgitant fraction is much more objective. So important is the picking up the best from each modality.
Definitely, definitely.
Željko Đurić, cardiac surgery. So I have a question. So when you would estimate regurgitant volume or ejection fraction, you would rely on MR or echo?
If you can have MR, you would choose MR. But it is a very expensive modality. It is not portable. Very small patients have a problem with staying still. So actually, it is a luxury. And the real strength in this current era, because a lot of my presentation was about future direction and how 4D can lead us to a more tailored approach. But in this current era, it is mostly used in patients where you can have it. And in most centers that would be above the age of 12. And when you really have a big discrepancy in echo, or you really want to have a good look in the anatomy and you don't want to expose the patient into ionizing radiation.
Yeah, I would agree. So then MRI would be certainly considered in the older patients. You know,
I'm sorry, if that was a question, I didn't catch that because it was...
No.
Sorry.
It's the microphone issue. So this is the beauty. We still need to use the brain, right? So
definitely, the brain is the best modality. That is true.
So if you have a borderline case and not clear clinical symptoms, so then it's better to do the MRI.
Oh yeah, definitely.
Yeah,
that is where it really shines.
Yeah, if you have
borderline cases, because you know, eccentric jets, multiple jets, echocardiography can be a pain with these cases. And if you don't have symptoms, this is the thing with the new guidelines, isn't it? That you have to rely on indices rather than on waiting for symptoms, because it's all about ventricular recovery.
You know, my approach, it's very individual. So if you have the case, you have the Z-score for left atrium +5 or +8, you have the very obvious source of the regurgitation, you know where it is coming from, then you don't need to rely whether this is 30% or 45%. It's much more important to know how to treat it. And how to treat it, the information is much better provided from the 2D or 3D echo, right? Because you can exactly describe where the problem stands. You can speak to surgeon, and you can navigate the surgeon even in the theater with the TOE. And we can do the 3D TOE now from the babies of the weight of the 4.5 kilos.
Yeah.
So this is the kind of the comprehensive assessment, and then you reserve the MRI for borderline cases, for the cases you need to assess the myocardium, because if you have the left ventricle outflow tract obstruction with the endocardial fibrinostosis, you must have the MRI. So we need to know really, again, what I'm saying, to pick up, to take the best of each modality, right?
Yeah, definitely, that is true.
Okay, thank you all of you for a good discussion. Now